Respected chairpersons, at the outset, I would like to thank the organizers for giving me this opportunity to talk to this elite group of audience on the topic Charcot's Neuro Osteoarthropathy. At this juncture, I remember my professor and I thank my professor, Dr. S. Ramar, who taught me the alphabets of PMR. I welcome every one of you for this presentation. This is the profile of my institution. We have a podiatric clinic in our department. The motto is healthy feet for happy life. And the mission is to prevent limb loss among the diabetics. February 18th, I received this message in my WhatsApp. I regularly come to 200 Medical College for MD examiner as an examiner. We are in touch with Dr. Selvan. He sent me the message. When I go through the brochure, this diabetic foot care, this impressed me. I asked him whether I can come and talk about a topic on diabetic foot. He said yes. When he said it is organized by the Kerala chapter of IAPMR, whether you permit people from other state, he said, you are most welcome, sir, and I am here. A 60 years old Mr. M, a type 2 diabetic, for the past 18 years was referred to the podiatric clinic from the urology department to attend his feet. On examination, he was found to have fissures in both feet. On careful examination, he has pain and swelling of the left foot for the past 3 weeks, and he could not perceive vibration and monofilament sensations. So this patient presented with unilateral swelling and pain in the ankle and foot. Single elephant is always dangerous. Any diabetic patient present with unilateral swelling and pain in the foot, you must always consider Charcot Neuro Osteoarthropathy. When we examine the patient, he has peripheral neuropathy. He could not detect the 10-gram monofilament. He has peripheral neuropathy, large fiber neuropathy. He has normal dorsalis pedis pulsation. The temperature between two sides of the skin on the feet are different. There's a difference. We do this with a digital thermometer. History of trauma, he is not aware because of the large fiber neuropathy. He has long-standing diabetes, 18 years duration. He easily fits into Charcot's risk group. This is an X-ray of the patient. We always have to take the X-ray of the ankle as well the foot, epilateral, and the X-ray of the foot, oblique view. And the answer is here. In our hospital, we have the facility PACS, the picture archiving and communication system, where you can you can magnify the image. Here, the X-ray foot shows there's a reduction in the bone density, osteopenia. The articular margins of the second, third, fourth metatarsal bases are destroyed. There is no joint space. This is the characteristic radiological features of Charcot's Neuro Osteoarthropathy. And thanks to Dr. Jean-Martin Charcot, he is a neurologist from France. He is called Napoleon of neurosis. He is the first person who described multiple sclerosis. He is the person who first described Charcot orthoneuropathy. He is known for his work on hypnosis and hysteria. We started our podiatric clinic in 2001 during the second wave of corona pandemic. We used to get the similar type of patients periodically. So far we have treated 60 patients in the past 5 years. I always wonder what happened to the patients, why they have a localized osteoporosis, osteolysis, bone resorption. There's a rocker bottom deformity. When I read more and more, I got the answer. So you all know in the blood we have RBC, WBC, platelet. In the WC we have granulocyte, lymphocyte, monocyte. The culprit in Charcot orthoneuropathy is monocytes. Monocyte release cytokines. Cytokines are chemical messengers that modulate the immune function. The cytokines signal the immune cells to fight against the invaders. There are two types of cytokines, pro-inflammatory cytokines and anti-inflammatory cytokines. The pro-inflammatory cytokines are tumor necrosis factor alpha, interleukin 1B, interleukin 6 that trigger the inflammation. The anti-inflammatory cytokines, they stop the inflammation. They are interleukin 1, 4, 10, 11, 3. You and me, normal person, there's a balance between pro and anti-inflammatory cytokines. In patients with long duration diabetes, large fiber neuropathy, they have an imbalance. They have more pro-inflammatory cytokines that results in the signs of inflammation. You all know there will be heat, redness, swelling, pain, and loss of function. In Latin, they say rubercula, tubercular. So our patient presented with unilateral swelling, warmth, tenderness. Redness was not obvious because of the blood discoloration. You know, this is a cross-section of the spinal cord. It shows the formation of the spinal nerve, the anterior, the ventral root and dorsal root, they unite upon the spinal nerve. In the lateral horn, you have the sympathetic neurons. The sympathetic nerves also pass through the same spinal nerve. So when the spinal nerves are affected by the peripheral neuropathy, the sympathetic fibers are also affected. The sympathetic nerve fibers contracts the smooth muscles in the blood vessel. So when the sympathetic nerve fibers are activated, there will be vasoconstriction. In peripheral neuropathy, when the somatic nerves are affected, automatically the sympathetic nerve fibers are affected. So the smooth muscles are relaxed. There will be vasodilatation. The pulse will be pounding in the dorsalis pedis artery. So a patient with peripheral vascular disease or peripheral arterial disease is protected from developing Charcot's arthroneuropathy. So I have explained why this patient present with unilateral swelling of the foot because of the pro-inflammatory cytokines. Then X-ray, why there is localized osteoporosis or osteonecrosis or osteolysis. Again, the culprit is monocyte. You know, the monocyte differentiate into macrophage. It assumes different names in different sites. They are called histiocytes in the tissues. It's called microglia in the brain, mesangial cells in the kidney, alveolar macrophage in the lungs, osteoclast in the bone. Osteoclast is a multinucleated. It has multinucleated giant cells. It has villus processes. They lay over the bone. They release alkaline phosphatase that dissolve the organic and inorganic content of the bone. The bones are broken into segments. The fragments are taken by the osteoclast. In the process, calcium and phosphorus are released. And this is the result of the osteoclast activity, osteolysis. So in a patient, a long-standing diabetes, uncontrolled diabetes, he has large fiber neuropathy, he has numb feet, there is no sensation in the feet, he may get frequent injuries, which he is not aware. When repeated injuries occur to the foot, two things happen. Number one, the monocyte responds to the trauma and release cytokines. The cytokines elicit the inflammatory response. Second thing is Wrangle pathway. The pro-inflammatory cytokines, the tumor necrosis factor alpha, that stimulate the osteoblast, the immature bone cells, to release Wrangle. The abbreviation Wrangle stands for receptor activator nuclear factor kappa B ligand. It is looking for its receptor. The receptors are found over the surface of the immature osteoclast. That's called RANK, receptor activator nuclear factor kappa. When the Wrangle attaches itself with the RANK, changes happen inside the osteoclast. It releases nuclear factor kappa B and it becomes a full-blown osteoclast. Osteoclast causes the osteolysis. So I have explained why the patient presented with the swelling of the ankle and foot. This is because of the acute inflammation in the foot and the osteolysis or bone resorption due to the overactivity of the osteoclast. Investigation, in any case of inflammation, we used to test CBC, WBC, ESR, C-reactive protein, calcium, phosphorus, alkaline phosphatase. This is the guideline, International Working Group on Diabetic Foot. Whatever I talked from this guideline. The guideline says, we suggest not using C-reactive protein, ESR, white blood cell count, alkaline phosphatase, other blood tests to diagnose Charcot arthroneuropathy. Plain X-ray of the affected foot with ankle is enough for diagnosis. Then medical management is a disease of bone resorption. Every day we treat osteoporosis. So the drug of choice is the bisphosphonate. We have weekly once alendronate, monthly once ibandronate, yearly once zoledronic acid. Then we have the calcitonin nasal miacalcin. We have parathyroid hormone, denosumab. We have monoclonal antibody. These are the drugs we use for treating osteoporosis. We see what the guideline says. Do not use alendronate, pamitonate, zoledronate, calcitonin, parathyroid hormone, methylprednisolone, or denosumab for treating Charcot neuropathy. We suggest to evaluate the need for vitamin D and calcium supplementation. So the vitamin D recommendation is 600 to 800 international unit per day. Calcium recommendation 1000 microgram to 1200 microgram. In Tamil Nadu, we have this product Charcot. I used to prescribe 2 to take at a time that will supply 1000 milligrams of calcium and 500 international units of vitamin D. This is a guideline from the United Kingdom, Northern Diabetes Food Care Network. They say, to confirm the diagnosis of Charcot arthropathy, refer the person within 1 working day to the multidisciplinary food service for triage, and treatment should be within 1 further working day. They consider the acute stage of Charcot arthropathy is a medical emergency. The patient will lose the limb. So they have given only 2 days time. One day the patient will be sent to the podiatric clinic, other day treatment must be taken. Till the time, offer non-weight bearing treatment to protect the foot. So like that, we applied the total contact card. Very, very difficult to convince the patient. Thanks to Dr. Paul Wilson Brand, he was a physician, worked in Christian Medical College in the pre-independence period. He was working on the ulcers because of the Hansen's disease. The patients, he only introduced the total contact cost. Later, when he moved to US, he introduced the same in the United States. The plantar pressure with the barefoot at the 4-foot level, it is 100 kilopascals. When a patient uses offloading footwear, it is reduced to 50 kilopascals. With total contact cost, there is no plantar pressure at all over the 4-foot region. So the best offloading device is total contact cost. So we apply total contact cost. We offer non-weight bearing walking. So every 15 days we remove the cast. At the end of the removal of the second cast, this is the X-ray, the bone showing signs of healing. This is the X-ray after the removal of the 6th cast, after the end of the 3 months. How beautifully the bones have healed. So this is how on the left side he presented with. Now the bones are healing. Okay. Once the signs of inflammation has gone, fracture, the bone healing has occurred, we allow the patient to weight bear with a special type of offloading footwear, heel to toe rocker bottom footwear. Okay. This disease passes through 4 stages: inflammatory stage, developmental stage, coalescent stage, remodeling stage. Inflammatory stage, the patient present with signs of inflammation in the foot, warmth, tenderness, and swelling and redness. Development stage, apart from the signs of inflammation, there will be radiological features of the osteonecrosis or osteoporosis. Coalescent stage, there will be signs of healing in the bone. Remodeling stage, the patient presented with rocker bottom deformity. This patient came to us in stage 1. He has signs of inflammation as well radiological features of Charcot arthropathy. Diabetes patient any doctor can treat diabetes. In the first 10 years, you may not have any problem. We have an array of drugs. Anybody can treat diabetes. But once the patient develops complications, diabetic retinopathy, proteinuria, MI, we may find it difficult. We have to refer the patient to the specialist. Okay. So you are treating one diabetic patient for years together. When the patient develops Charcot arthropathy, it is a disgrace to your practice. See, this patient has come to you in stage 0 itself with pain in the ankle and foot. You might have missed that. You might have written some NSAID or you prescribe some antibiotic considering it's an infective arthritis at the ankle joint. You miss the finding, that is why the patient presented with a rocker bottom deformity. So the differential diagnosis you have to think in mind. The septic arthritis, osteomyelitis, cellulitis, the non-infective causes, gouty arthritis, pseudocoat, osteoarthritis, inflammatory arthritis, and the pseudox atrophy. The take-home message, the clinician must be very suspicious when a diabetic patient with numb feet presented with unilateral swelling and pain in the ankle and foot. Immobilization in a total contact cause is the treatment of choice. Except X-ray, no other investigations are required. Calcium and vitamin D are the drug of choice. If you are able to identify and treat this condition in an inflammatory and developmental stage, that is stage 1 and 2, destruction of bones and development of rocker bottom deformity can be prevented. This is our team. So why this topic is presented to the young physiatrist? See, we treat many arthritis patients, monoarthritis patients. So whenever you come across a patient with ankle pain, a diabetic, long duration diabetic, large fiber neuropathy, consider this as a first diagnosis. Then simple intervention, total contact cause, you can do in your department. Third one, we have a prosthetic, you all have a prosthetic arthritis center in your institution, so you can make the offloading footwear. So this is our prosthetic arthritic center. So we make the following offloading footwear. For a 4-foot ulcer, we have 4-foot rocker and 4-foot clock. For the mid-foot ulcer, we have mid-foot clock, the scooped out insole and Bogler iron orthosis. For hind-foot ulcer, we have hind-foot clock, heel-to-toe rocker, molded shoe, and Bogler iron orthosis. Why the disease affect one side of the ankle and foot? Why there is unilateral involvement of the ankle and foot? Still, I do not know the answer. I would like to hear from the senior faculty members here. Thank you very much. So, in our institution, for every 3 months, we conduct diabetic foot workshop, and these are the topic we discuss. Assessment of the diabetic foot, management of diabetic peripheral neuropathy, diabetic footwear for diabetics, offloading footwear for diabetics, peripheral arterial disease rehabilitation, Charcot's neuroarthropathy, and surgical offloading technique. The postgraduates and the young faculty members can attend. Thank you very much.
Thank you, Dr. Rehabcon.